Welcome, everyone, back to another edition of Disruptive Dental Science. My name is Dr. Ashton Prince. I am one of the clinical ambassadors here at Dental Advisor, and I am thrilled to be joined by someone that I could sit and talk to for hours about clinical things, about stupid things. It really doesn't matter very much as to what we would actually be going off of. But Dr. Paresh Shah from our land to the north of us, from Canada. Paresh, if you wouldn't mind doing us a favor, kind of introduce yourself. Tell us who you are.
Sure. Thanks very much, Ashton. I'm I'm practice in Winnipeg, Canada. And if you look at the map and cut Canada in half, I'm right in the geographic center. So it's right in the prairies above Minnesota, North Dakota. So if you're wondering, hey, is it cold? Yeah, you're darn right. It's cold in the winter and it's hot in the summer. Right now, it's actually great weather, but it's a great place. I've been practicing for 33 years. I'm a general dentist. Do all types of dentistry, but I love doing a lot of interdisciplinary dentistry. I've got a couple of specialists in my practice. A young prosthodontist that started this week part-time, and I've got a periodontist part-time, and then my orthodontist and oral surgeons and endodontist are 10 minutes away. And
Yes.
so I love doing that. Done all my education here. And then our daughter's a periodontist, but she didn't decide to stay here. Got married and moved to Westchester County in New York.
Well, I'm actually kind of excited to hear that you've got those different views, those different dynamics when it comes to the dental field itself. Because for myself, there's so much that we need to be looking into in dentistry these days that we can't
Sure.
just look at a tooth. Let's say that someone comes in and they've got a broken tooth. The way that I was trained back in school was, well, all you've got to worry about is just putting a crown on the tooth or put a filling
Right.
into it. Just rebuild the tooth and you're done.
Yeah.
It hasn't been until the past number of years, I should say few years, that now I actually look at things and say, okay, so why did the tooth break in the first place?
Right.
Was there a fracture line? Was there something in the excursions that actually caused for this to happen? I mean, there's so much more that goes in to our treatment planning these days that we have to keep our eyes very, very open. So in your field, with as many interdisciplinaries as you actually have, are there certain dynamics that you're looking at in your own personal practice that you say, this is something I'm kind of focusing in on right now?
Yeah, oh, that's a great question. So I agree with you. Like in terms of I think when we get out of school, just to digress slightly, like we're trained as a good like as a technician. I don't think we can we're as adept at being diagnosticians for looking at the big picture because I don't think you can teach that in a short period. And I mean, 4 years is long, but I just don't know if you can in there,
Not long
especially
enough.
well, yeah, exactly, when requirements and everything are there. I think we come out skilled to treat teeth or to fix a problem, but it's very hard to look at the other things. And so in my practice, um, it's just through years of mentorship, of making mistakes that you don't know what you don't know,
Sure.
and learning through courses and things like that, that it's like, okay, I got to look at more and ask why. And so I spend a lot more time asking why. Some of the answers I already know why, but it's important to kind of convey that a little bit, express that a little more vocally when a patient's there, so that they understand, or a team member understands why you're saying something.
Mhm.
Like even in a hygiene exam, like my hygienists are fantastic and they'll highlight certain points, but to tie it in for the patient, I'll kind of say, okay, those findings are great, but here's the reason why we're bringing it up, so that we can actually have the conversation, give the patient an idea of why
Yeah.
we're actually bringing up these questions and addressing these concerns.
So
If that makes sense.
it absolutely does. And from your conversation piece that you just had of you really just don't know what you don't know. And for the things that you haven't been taught during those very, very short few years of dental school that we have,
Right.
to think that we are the most brilliant minds coming into the dental field, which is what we all think when we first come out into
Yeah, for
dentistry. We,
sure.
we think we know everything, and we find out
Yeah,
very, very quickly that we don't.
right.
But I guess for those that are listening that are are trying to understand what it is that they don't know because they're not even aware of what they don't know until they have that moment come to them like, oh
Right.
no, I should have looked at that a little differently. Is there a certain spot that you begin? Do you begin with the different topics of is it the dentition? Is it the joint displacement? Is it the airway? Is it orthodontics? I mean, where is it that you begin for your own
You
practice?
know, okay, so it's interesting you asked that because, and I bet you've been practicing long enough that probably people come up to you and, yeah, I want to learn how to do more veneers. I want to learn how to do this and that.
All the time, yeah.
And so one of the first things I tell them, I go, truthfully, if you really want to learn all that, you need to learn about occlusion. You need to learn how to diagnose the entire mouth. And it's not a sexy topic.
Not
And
at
you know what I
all.
mean? Like it's more like, when you're looking at, Newton Fall doing his layered composites,
Uh,
that's cool,
that's
you
sexy right
know,
there.
right? That is. And so I always tell them, I go, listen, if you want to make an impact right away, take a really good course on composites and you can implement the next day. Or
Yes.
take maybe a course on, a single tooth endo and how to diagnose and treat it, and you can probably start it the next day, not a molar. But most of the others, you got to learn how to manage occlusion. You can take a weekend course in implants, but if you don't know how to diagnose if it's going to be in the right spot and if you can restore it, what are you going to learn?
Yeah.
Like, what's the point? And so part of it is talking to them about that. And I think one of the things that that is helpful is when we're talking to patients and when we're looking for things, like to look for like crowded teeth or looking for wear, because a lot of that is a lot of that is an entry point to comprehensive dentistry. Because if we're just,
Right.
if you can do it restoratively, but it can be very aggressive. A lot of people want, I hope I'm not going on a tangent. Stop me at any time. But a lot of,
We're gonna go down some tangents, buddy.
yeah,
It's
we
okay.
are. But a lot of people, they want minimally invasive.
Sure.
Patients want minimally invasive. But when a lot of dentists, like our forte is restorative dentistry.
Hmm.
And there are times where we can do more predictable, longer lasting restorative dentistry if we address the root cause of the problem and how the
Right.
teeth got that way.
Right.
And again, you don't know what you don't know. Like, how did I learn some of it? Because, when first you see a broken tooth and it's like, oh, well, you're going to need a crown. Like, you've lost two cusps. So let's do a crown. And then you do it
It's
and you wonder why the porcelain fractured, like,
exactly
you know, 3 years later when, you know, grandparents' gold crown's been there for 40 years.
one of the hardest things that I've ever had to do is look back at my first full mouth rehab case that I had almost 20 years ago. And they came in and they started having little chips and pieces and things that were coming off. And I thought, well, why in the world is that happening to you in the first place? Granted, 20 years, that's a decent amount of time. I'm
It's a
okay
long
with
time.
that. But at the
Yeah.
same time, I started looking back at the case and I thought, well, how did I miss this? How did I miss that? Where
Right.
did I miss on this one?
Mm.
And there's so many little intricacies of things that actually go on. So as we start going through, I even had a case just this past week where someone came in and they said, I saw a previous dentist and they told me that there's nothing that they can do for my mouth. And the attrition was horrific. There was a lot of
Right.
erosion. I mean, their overbite was absolutely terrible. There was no overjets. I mean, they had
Right.
completely collapsed. There was no video. It was a bad case. And I said, well, I hate to tell you this, but there's plenty that you could do. I just kind of get the feeling that your previous dentist might not known what to do or how to go about this, and it might have made him a little bit scared.
Right.
There's a massive aspect of confidence that comes into this.
Correct.
If you don't have the confidence in your skills or what you're doing, it's what I tell dental students when they're going through, or go ahead and get your degree, but when you get out of school, we'll teach you how to be a dentist.
Right.
So where did you build your confidence? How did you actually go about this?
So, so I bought my practice. I took over practice from a retiring dentist about 3.5 years out of school. And then
Uh,
I'm seeing all these patients, did a lot of good work and but a lot of restorative work that he did, and lots of pin amalgams, and they were lasting.
uh,
And metal ceramic crowns. But I had a lot of patients who were coming in with wear, and they had like teeth that were out of alignment. They had occlusal plane discrepancies. I didn't even know that term back then. And and
Did it exist 33 years ago? I'm
yeah,
not sure that it
I don't
did.
know, but it was like one of those. And then but it sounds cool, right? If I say that, people will be like, "Oh, that's a really nice term."
Like, oh, he
But
knows what he's talking about.
yeah, but and they're going like, "Can you fill this gap? Can you do this?" And I'm scratching my head. I'm going, "I got nothing for you unless
Sure,
you want to do ortho. I don't know what to do." And
sure.
they're in their mid 50s to mid 60s, a lot of them, and they're like, they think I'm from Mars just mentioning ortho because it's the only thing. I don't know what to do unless you're pulling out a whole bunch of teeth. And that's kind of was an impetus for me to go, I need to know more. And that's where I ended up heading to the University of Minnesota, and there was a continuum there. They called it the aesthetic continuum, and I was one of the first people to graduate from the program at University of Buffalo. But they taught me about comprehensive dentistry because there were two prosthodontists that ran the continuum for several years, along with Paul Belvedere. And and so but that's kind of I just got handcuffed because I didn't know what to do, and I wasn't able to tell the patients enough. That's when I slowly started, taking courses at Mish, and then going through Coyce, and then doing some Spear courses, and then all the Seattle Study Club stuff that I've been doing. um, but for me, I want that was an aha moment to say, oh man, there's so much I don't know.
So in
Is
other
just
words,
looking
you've got
and
to
not
find out.
knowing what to tell the patients rather than just, oh yeah, I'm just going to spin the teeth down, because I figured there had to be more than just cutting teeth down.
Yeah. We can live a career of just doing what it is that we've been taught. It's not a very
Right.
fun career, if you ask me personally. There's a lot
Yeah.
more entertainment and joy when you actually can take someone that doesn't have answers otherwise and say, let's you and I look at this a little differently. Let's open up the
Right.
box a little bit. Let's see what we can actually do.
Right.
So I was in the same boat with it. I actually started off with Frank Spears and had him start me off that occlusion course.
Right.
And it was at that point that I realized that there was so much more that I could do to help out these patients that were coming through that had, if you're looking down the future lines, how much worse they would have been off if we wouldn't have started a little bit earlier into their treatments.
Right.
Now, when we use the term interdisciplinary,
Yeah.
we're not just talking ortho, we're not just talking crown and bridge. I mean, we're talking just about everything else. So, what else on
Correct.
your list do you include into an interdisciplinary process?
That also, like all the specialties, including a lab. It's
Yes.
all
Oh,
part of the
yes.
whole thing. Yeah. Yeah. So it's the whole thing. So um, I still there's an article that I have cited in my from Frank Spear, in my lecture, and it's something like this: if the arrangement of the teeth and in the arch is uniform, and all the gingival levels are uniform, this is
Mhm.
basically a restorative case. You just go in there and you can change everything. But
I've heard him say
the
that too. Yeah,
the
that brought back
moment
some
the
memories. Yeah.
gingival heights or the arrangement of the teeth are not appropriate,
Sure.
you have to tell the patient it's an interdisciplinary diagnostic issue. You
Yeah.
have to. It's up to the patient to decline, but it's our
Ooh,
obligation to tell them, listen, your gum lines are out of whack. Well, what do you do? Oh, I saw on Instagram that you can laser it. I go, yeah, but you can also see my orthodontist, or you can also see my periodontist, or you can accept that the gum heights are going to be different. But don't you feel it's an obligation you have to tell them? You don't just ignore that.
oh, you're killing me. In fact, I was about to jump right over everything you were saying there. So when you have a patient that sits in your chair, very, very seldom are you actually going to have somebody that starts asking you that type of detailed question. Usually it has to come from you to start calling
Correct.
attention to what is
Correct.
happening to them.
Right.
You might get that one fluke that goes on that says, you know what, I really just don't like the looks of my teeth. Usually you have to say,
Right.
so what is there about your bite that you don't like? Or how's
Right.
your chewing been? Do you have some digestive issues? How's your airway? Are you snoring?
Right.
There's so much that we can go after, but if we don't bring it up, to say that it's an obligation, that's an understatement. I mean,
Yeah.
really and truly, if you know what it
Yeah.
is that you're talking about, you have to. If you
Right.
don't have any idea what you're talking about, maybe keep your mouth shut and maybe,
Yeah. No,
don't
it's
screw
true,
it
right?
up by doing
Yeah,
something you
don't screw
don't
it up.
know.
Right, exactly. So part of like how do I bring up interdisciplinary? I always look at that. I just look at everything. I bring up exactly what you're saying. Like if you got a person with um crowding,
Yep.
and we're taught if you do, I do very little, aligners and stuff. My best friend's an orthodontist. We do so many cases and he's 5 minutes away. But the thing is, I do a handful. But the thing is, we're always taught, hey, you look at lower anterior crowding and that there's an issue there. And automatically an entry point is talking about ortho. But often when that happens, you've got wear or you've got teeth displaced in the upper arch because they match together. And then next thing you know, there's wear, there's attrition. And so what I feel is very important is that I feel it's an obligation to us to at least tell the patients whether they're 18 years old or 78 years old. Well, it's a little different when you're 78, but you know what I mean. Like when they're
The
like
motivation's
18.
different.
Yeah, the motivation's different, but at least letting the people know so that are younger that, hey, look, this may not fit in your life right now, but I'm just letting you know if we don't address these issues by the time and I can say when you get to my age and when you get even older, no, I do say that. I said,
I
you're going to
can't
have
say that yet.
problems. Yeah. Okay. So I just tell them, I say, look, you're going to have problems.
Oh,
And I hope that you're healthy enough to be able to go through the treatment at that time, because you may be on medications. You may not be able to have implants. You may not be able to go orthodontics. But I mean, you're going to end up having all your food stuck because everything's going to be tipping. You're going to have sensitive teeth. I mean, there's all sorts of ways. So I try and bring that out. Oh, what do you do? And I go, well, there's some preventative things we can start right now. Maybe to address this, it's doing some orthodontic treatment and just doing some conservative composite resin bonding just to protect the teeth and put them in the right spot until you're able to go to something else. Or
sure.
let's line up the teeth a little better and give you an opportunity to place implants or do bridge work at your pace. But let's address the wear and these problems that you have right now.
So there's when a patient sits down. So here for a second, I want to see if we can get something of value to those that are listening in on this,
Okay.
of where it is that they should kind of begin. So
Okay.
when you're sitting down with a patient,
Yeah.
I'll ask, what is the first thing that you see that makes you think to yourself, okay, we got to buckle up. This is a conversation that we need to have. Is it the wear that is your first call? Is it the crowding that is your first call? Because when you get all these interdisciplinary
Yeah.
pieces, there's so
Yeah.
many of me. I can't look at all of them right out of the gate. So
No.
what is the thing that you actually see the very most to start off with? That you're like, okay,
Mm.
the conversation's got to be had.
I would probably say wear. I mean,
It is wear. Okay.
yeah. As soon as I see crowding, I look for wear right away because there's something somewhere. Either, yeah. So I
As
look for wear. If there is wear, then what I'm doing is I'm looking like what's going on, how severe is it, and then try and figure out like what kind of wear is it. I mean,
exactly.
we know that we've got attrition. We know we've got abrasion. We know we've got abfraction. We know we have erosion. I mean, those
Right.
are the four
Was your
four
four? Yep.
main types. And there are times where all four of them are in there. And
Yeah.
you've got to
Very
figure
true.
out like which one is where as well. Where? Sorry. You know what I mean?
Bad play on
In
words, but I
in
got you.
what area of the mouth each one is happening. And we also have to figure out what's active or not.
Yeah.
Okay. And I've had that conversation this week with a couple of people. I'm meeting you for the first time. You have this where, yeah, I've been told I grind. I go, you know what? I don't know if you really grind. I
You
think your
did.
teeth are, yeah, I said, you've worn those off, but I think your teeth are misaligned. And when you function and chew, they're colliding in a way that's not ideal.
Sure.
So yeah, you might gnash your teeth a certain way, but I think you got a bigger problem than that.
No.
Tell me more.
Yeah, it's the fun when you actually have the way that it was initially before I started to open up my ears and eyes a little bit was if somebody came in with some wear, then I really wasn't even that concerned, if we're being honest, as to which
Right.
style it was. It
Right.
was, well, let's start you off with a wax up. Let's see if we can increase your VDO. Let's see if we can actually throw things together. And then if you didn't know any better, you just did it. You started
Correct.
trimming
Yeah.
things up, and then you started to see the potential failures that came. Or if you
Right.
got lucky enough,
Yeah.
then things were aligned well enough that you didn't
Yeah.
have the failures afterwards.
Right. Yeah.
Was that good enough? Did
Yep.
I do a good enough service to the patient to say that
Right.
now this issue's been taken care of? In the past, my answer was yes.
Yeah.
Is it now? Not even close. Not even close. There's too much more that I actually have to start looking into. So now, do I understand the airway completely? No, I
Right.
don't. Do I
Yeah.
understand how orthodontics work? No. My father was an orthodontist. He told me if I
Yeah.
ever got into that field, he'd disown me because I wouldn't know what I was talking about.
Gotcha.
So there's enough that we can start looking into with this kind of thing where
Right.
we've really got to take a step forward for this
Right.
interdisciplinary dynamic and say,
Yeah.
here we go.
No, you're right. You know what I wanted to say, which I love, is that at least you didn't do what a lot of us have done early in our careers, and a lot of people still do, is, oh, you need a night guard. Well, it's true,
I
right?
did have a period of time I did that.
So
Yeah.
did I. And I do make them. And then when you listen to, Spear and Coist, they're like, look,
Uh-huh.
the number of people that are actually truly bruxing, it's a very small percentage. Like
Absolutely.
it's
Yeah.
like 10, 11%. It's not a large amount. So it's usually a dysfunction of some sort.
But it's
But
an
we're
easy
not
money
taught,
maker.
right? It is, but it's a short-term band-aid, right?
Yes,
And all of
absolutely.
a sudden, so there's two things, like from an ROI and from a practice builder point of view, if we've
Mhm.
educated the patient to understand that, we can even figure out a way to stage them over 10 years. It doesn't matter. There's ways to do that. If you understand occlusion and understand how to manage things properly, you can do it in a year, you can do it in 5 years.
Yes.
So, but if you build that trust and get that patient to do that, you got a patient for life,
Yeah. Without a
right?
question. Plus all their
Right.
friends.
Right, exactly. But when you say all of that, like where do you start? Like it's not ignoring the wear and not putting, like, it's easy for us to see, like, there's three teeth that are worn. Hey, let's stick crowns on them.
Yeah.
Oh, I just did three crowns. But the crowns are really super shallow. They're very thin. The coronal height, we don't have a lot because everything's worn, because we've lost prosthetic space. We've lost restorative space because of the wear.
Sure.
But a lot of people aren't recognizing that. They're like, oh, it's worn. And now you end up doing an endo on a tooth that you don't need to do endo on, but it's a
Sure.
bigger issue. And so it's looking at all that and going, look, we have a bigger problem. And I just had this conversation with a patient last week, and I said, look, I can address these three teeth. They're going to be super tiny and short. And I show them on the scanner and I go, you see how short they are? Let's look at the x-ray. You see how short they are? They're all worn. And our teeth are funny because what happens is, as they wear, it's through friction and you start losing your teeth, they continue to want to make contact. And they go, well, why can't you just put something in there? There's no room to put it in there. It's not broken, it's worn. So let me show you something. So what do? I just dry the tooth off. I put a thin layer of composite on there. I
Mhm.
cure it. I get them to bite down. And they're going, well, I can't bite. I can't get my teeth to meet. And I go, there's no room. So this is what I'm saying. I can't put a filling on there. So either I got to cut this whole thing down to a stub and then put
Or,
something on. But the next thing that's going to happen, you're 35, when you're 60, you got an implant. There's no crown left for you.
right.
Okay. But if we address this right now and figure out a way to address this, I can get you to 60 or 70 and still have options to do crowns down that time. What would you like to do?
Sure. You
Okay.
you put the ball back in their court. I love it.
Right. And so there's little ways, but a lot of us are. So I just said to the patient, I go, look, I can shave these all down, but it's a bigger issue than that. We need to open up your bite. We got to create room, and that's involved. There
It
is an
is.
expense to that. But if you want to keep your teeth for the next 30 or 40 years, you really got to start thinking about that. And we
Yeah.
can figure out ways to do that. And then the other way to do it is a full mouth rehab.
Yeah. Which is the way that most people will go after it anyway, just
Right.
because they don't want to go through the
Yeah.
rest. So
Or
there's this thought that keeps coming through my mind as we're talking about this, and it still is the way that you present yourself, the way that you actually discuss things with patients and let them know that the decision still is always going to be up to them.
Correct.
But at the same time, you don't know what you don't know. I
Right.
had a patient that came through that had a small chip on a lateral tooth. The rest of the teeth were completely out of place. Most of them were I mean, it was a mess for everything else. And he came in and he said, "I've just got this one little chip. Can you fix that one chip?" And now this is probably about 10, 12 years ago that this happened to me. And I said, yes, I can fix that chip. That's fine if that's what you want. But you need to be aware that there's so much more we could do if you would like. And it took just that conversation, just that sentence there for him to say, well, what else could I do? What else is going on? What else should I even be thinking about? You need to be ready for those conversations as they come up. So, for you, Paresh, you said at the very beginning is that there are so many different disciplinaries that are associated with this, and there's so little that as restorative dentists like you and I are, that we would love to say that we are proficient in everything that we do.
Right.
We can't be that proficient in absolutely everything. So we need the help of the specialists. We need the help of those that are associated with
Correct.
us from every interdisciplinary dynamic. Would you agree with that?
No, I totally agree. And I was a super dentist, and I still do. And now
I didn't want to use the term, but that's exactly what we use.
yeah, but I'm not anymore because I just realized there's certain things that I enjoy more, so I enjoy doing them more. And if I'm not doing the other stuff as much, like I just let's get someone who does it on a regular basis, and we can just, our the predictability and the stability of our work is just going to be that much better. You brought something about you saw your stuff at 20 years, and it's
Mhm.
lasting, and at the same time you questioned yourself. Well, that's part of the whole thing, is like I worry some of the younger generation, and my daughter's in that. She's in her early 30s right now. I don't feel she'll be that way because of the influence I have, and my our circle of friends. But you've got to do work, and you've got to see your work, and you've got to see it last over time. And you and I have had an opportunity to look back and see the work that's worked and some of the
Uh,
work that hasn't, and go, okay, like this, no, 20 years, that's pretty darn good. Like, what hasn't worked well? Is there something I can do for that next 20 years? And what can I do for Mr. and Mrs. X next week that I can get them 30 years out of it?
it's the humble
Right?
critiquing that we have to do to ourselves.
Yeah, because like showing a 1 year follow-up, I mean, that's, you can chest thump all we want, but the reality is, you know, like, what is it going to look like,
You can make anything
later?
look good for 15 minutes,
Absolutely.
you
You take
know?
that post-op picture, and that's part of the problem with everything on social media right now.
Yeah.
We're seeing that instant thing, and it's like, oh man, God, you did a great job of fixing this tooth and resurrecting it from the dead, and I love it. Like, a direct composite, and meanwhile the oral surgeon's going, I would have been cold steel and sunshine. But there's a medium in between there. but
There it is.
um
Well,
but yeah, follow-up is important. I think it's important for us to be,
to learn it.
I and to figure out, like, what can we do in the most conservative manner to treat this wear and provide you with options, so that as you get older you don't need a rehab.
Right. Well, I would dare say that for those listening in, if this is something that you want to be able to build some confidence in, if you want to better understand, just like what Paresh has been saying, what I've been saying as well, if you want to learn these skills, you can. I mean, there's plenty of CE courses out there that you
Yeah.
can go and learn this kind of stuff. And if you don't really want to put forth that much effort, or you don't even know where to really begin, one of my suggestions to you would be is find your local specialists and sit down with them and say, I'm looking into to starting to better understand the treatments of what would you do in these cases.
Yeah.
Train me a little bit, and then you start to form that relationship between the two of you so that you can work together when it's said and done. Now, I also know that you do have a potential course coming up that you're
Yeah,
teaching as well,
actually,
correct?
with a colleague of mine from Toronto. Her name is Nada Albatich, and we both love lecturing on interdisciplinary care and on wear and everything. So we're actually doing a course in our First one's going to be in Calgary, Alberta in March, but we'll have other dates and cities after that. But it's going to be a 2-day course, and we're basically so we're going to be talking about a lot of the like some of the things in terms of diagnostics, but we're going to be doing where we're going to teach how to do different preps for different teeth.
Nice.
Some of them added, like a lot of them additive, some of them a little bit subtractive and additive to be able to, change vertical, address the occlusion, provisionalize, but also address, well, what if we didn't want to necessarily do restorative on every tooth? What if we only wanted to do it on the teeth that needed it? How do we involve perio? How do we involve ortho?
Yeah.
All of that.
Options, giving people
Options.
options.
Yeah.
So how do they find out about your course? Have you got a website or
Um,
anything?
you know what? Right now, we will. Right now, I guess through Instagram. Right now, you can reach
Okay.
out at Dr. Paresh Shah, and then we'll probably have a website
I love it.
link from there
Beautiful.
shortly.
Well, and for the continuing on for things, I mean, you've really inspired me to be thinking about how it is that we can approach other dynamics of this, other
Yeah.
specialties into it.
Yeah.
So I'm gonna hold you to this, but
Yeah.
I'm thinking that we might want to do some return visits of
Sure.
actually going from specialist to specialist, bringing in a lab technician, bringing in
Oh, yeah.
orthodontist, and have you actually visit with them as well and actually see what it is that they see with a basis behind when a patient sits down and you're not sure where to start, where can we begin? So I'm going
Absolutely.
to hold you to that,
I,
which
I
means
love this stuff. I do. I absolutely do. And I think you do as well.
I do. I can't get
I
enough of this
know.
kind of
I
stuff.
know.
So for
Yeah.
those that have listened in with us, if you're wanting to learn a little bit more about what it is that Dental Advisor is, who we are, and the things that we can actually help you out with from different materials, different equipment, look us up on dentaladvisor.com. There's plenty of resources and things that are there. Paresh, my friend, thank you
Oh,
very,
I
very much
appreciate
for
it very
joining me
much.
today.
It
You're
was
a
fun.
joy. Honestly, it's such a
It's
good
a
time.
blast.
So,
We'll
so
do
for all
more.
those listening in, thank you once again for joining us on the Disruptive Dental Science podcast, and we'll see you next time.